Hello, everyone. Welcome to the Fireside Chat. Today, we're gonna have the session with Dr. Sarah Holmes on optimizing meaningful activity for persons with dementia. My name is Chusa Moon. I am an associate professor at the College of Nursing at the University of Iowa as a member of Education Committee at the National Center for Gerontological Nursing Excellence. I'm very honored to have June NHCGNE Fireside Chat. This is a free monthly series, and this session will feature distinguished educators in gerontological nursing and other experts in this field, sharing insights on key topics in gerontological nursing. Each chat begins with a brief presentation followed by an informal discussion where you can engage directly with speakers. Today, Dr. Sarah Holmes is joining us as a speaker for today's session. She's an assistant professor of organizational systems and adult health at the University of Maryland School of Nursing. She specializes in long-term care services and quality of care for older adults. Dr. Holmes's research focuses on developing and testing interventions for improving the care environments in long-term care settings to optimize quality of life and increase opportunities for meaningful activity among residents with dementia. She also practices on an interdisciplinary wellness clinic team serving low-income senior housing communities in Greater Baltimore area to increase access to care and promote the health and well-being of residents. In the next 15 minutes, Dr. Holmes will talk about optimizing meaningful activity for persons with dementia. After her presentation, we'll have Q&A sessions and discussion sessions. Of note, I will leave a survey for you to provide any feedback for today's session. Again, thank you so much for Dr. Holmes and audience who are attending the fireside chat. Dr. Holmes, are you ready?
Yes, I am.
Wonderful. You may begin.
Thank you so much for having me, and thank you all for attending. I'm thrilled to be speaking with you, and particularly on this topic, and sharing some work that focuses on optimizing meaningful activity and really integrating it into the care provided for persons with dementia. So glad to be here. First, I want to acknowledge that I'll be presenting on some of my research, which was funded by the Alzheimer's Association. And I also am eternally grateful for my team of collaborators at the University of Maryland School of Nursing who were all part of this work. And I have no conflicts of interest to disclose. So the objectives for today's session, first, I'll define what it is I mean by meaningful activity, particularly for persons with dementia. Next, I'll describe an intervention that we developed to help optimize meaningful activity for addressing behavioral symptoms for persons with dementia. And then I'll describe some results, or briefly describe some results from a pilot study that we did to test this meaningful activity intervention in assisted living residents with dementia. So there's an increasing focus on non-pharmacologic approaches for addressing behavioral symptoms for persons with dementia. And meaningful activity is one promising approach. And so first I want to start off by talking about what it is I mean by meaningful activity. Let's do a little exercise. I want each of you to think about a time where you were engaged in an activity or doing something that gave you purpose or made you feel productive or accomplished or valued by others. So think about what you're doing when you feel valued by others or you feel a sense of purpose. And this is essentially meaningful activity, and it's meaningful to you. It may not be meaningful to anyone else, but it's meaningful to the individual. And in fact, meaningful activity is a person-centered approach. It's individualized, and it involves matching the activity with the ability and also the interests of the person in ways that bring them meaning. So I'm sure we all can acknowledge, when we've done something that's meaningful, it makes us feel good. And there's a lot of research that actually shows when you're doing meaningful activity, it helps to improve your physical, your social, emotional, and mental well-being. So when thinking about meaningful activity for persons with dementia in assisted living, some examples might be, or some examples from our work has been, maybe volunteering within the community, within the assisted living community by doing things like helping to set the table at mealtime, or planting or watering flowers in the community gardens, or even participating in your own self-care, doing things like dressing and grooming. Each of these activities can help the person with dementia feel a sense of meaning and purpose in the moment. And that also can be helpful for addressing behavioral symptoms like agitation or resistiveness to care. But unfortunately, in assisted living, we know there's a number of barriers to residents and persons with dementia participating in meaningful activity. Particularly for residents with dementia, they can experience, challenges self-initiating in activities or engaging and communicating with others as their cognitive abilities decline over time. Also, in regard to staff, we know they may lack the knowledge or the ability or skills to be able to effectively interact with or engage persons with dementia. And there's a lot of research that shows this. And then also considering aspects of the environment. I mean, even this image showing the difference that lighting can make in a community for residents to be able to safely navigate and interact with others in their environment. So the environment plays a big role in facilitating residents' opportunities for meaningful activity. But because there are these different barriers that often exist, assisted living residents with dementia tend to spend the majority of their time engaged in activities that are not meaningful to them. Most frequently, we see, residents, spending a lot of time watching television or sitting alone in their room or laying in bed. And so this is a real problem that we're trying to address. So this sort of led to the development of our intervention, which is called Meaningful Activity for Managing Behavioral Symptoms of Distress, and otherwise known as MAC4BSD. And MAC4BSD is a theory-based approach. So it's guided by the social ecological model and social cognitive theory, and it includes 4 key steps, which I'll go into a little bit more detail. The first step involves assessments of the environment and policies within the assisted living community. The second step involves providing ongoing training and education for staff on meaningful activities and engaging with residents with dementia. The third step involves evaluating residents' individualized preferences and developing goals for meaningful activity. And the fourth step is really mentoring and motivating the staff and the residents to be involved and engaged in meaningful activity. So to just review each of these a little bit more detail, the first step involves assessing the environment and policies and really looking for facilitators or barriers to meaningful activity participation. So this may include looking for aspects of the physical environment. I mentioned lighting or noise, or aspects of, factors that can affect residents' ability to ambulate in their surroundings. Also, we look for things like, is there access to supplies or resources for residents to engage in activities that are meaningful? Often we find that there is a wealth of resources and supplies in the community, but it's not accessible. It may be locked in a closet or in a cabinet, and staff and residents are not able to access it. And then we look for policies or procedures that may be in place, like evaluating residents' preferences for meaningful activity, and ways that we can modify any of these aspects of the environment or policies. And we do that as part of the intervention. The second step involves providing training for all staff. So we provide training for all direct care staff, nursing, activities, rehab, and we also include non-direct care staff like housekeeping staff, maintenance, dining services. All staff in the community it's important that they're trained and have education on, how they can interact with residents with dementia, the benefits of meaningful activity, and ways that they can help facilitate engagement and activity. The third step is really important. It involves evaluating residents' preferences and developing goals for meaningful activities. So this is really kind of how do we figure out how to make each day meaningful for the person with dementia. And so we do this using a tool we developed called the Meaningful Engagement Assessment. It's a very brief tool, as you can see on this slide, and I'd be happy to share it with anyone who's interested. But it essentially includes three components. The first is getting brief background information about the residents, about their personal life history. What was their occupation? What are some things about them that are important? And then going a little bit deeper into what is meaningful to the individual. I like to tell people, think about a time where you saw this resident really light up with joy or belly laugh, right? And so we want to replicate those moments and think about activities they were doing during those moments. So oftentimes we include information from the resident directly, the staff who work with them, and even family members. And then the third component, called Making It Happen, really combines the two other components and really thinks about how can we create meaningful moments and identify individual meaningful activities for the person. The fourth step of the intervention involves mentoring and motivating the staff and residents. So this is where we really kind of make it happen. We know that knowing what is meaningful to the person and completing that tool is not enough to change behaviors. So this step of the intervention really involves mentoring and motivating the staff using self-efficacy based approaches. We provide positive reinforcement and encouragement. We do coaching and role modeling for the staff. And really, when we see residents engaging in meaningful activity, we celebrate it. So I shared with you about the meaningful activity intervention. And so now I'm going to shift gears and share results from our pilot study that we did where we tested the meaningful activity intervention for decreasing behavioral symptoms among assisted living residents with dementia. So a little bit about the methods of this study. This was a cluster randomized controlled trial where the assisted living communities were randomized to either receive the meaningful activity intervention or education only. And there were 66 residents with dementia who were included in the study. And they had to be at least 55 years old. They had to live in the assisted living community to participate and screen positive for dementia. And we excluded any residents who were enrolled in hospice or admitted for short-term care only. We also excluded residents who had dementia due to a neurological condition that was not Alzheimer's related, things like a brain tumor or traumatic brain injury. We had a few different outcome measures, but our primary outcome was behavioral symptoms, and we measured that using the MPIQ, which was based on staff report. And we used descriptive statistics and linear mixed models in our analysis. So this is a slide, a lot of numbers, but it just shows the characteristics of the residents in our sample. I'm going to briefly walk through this. The average age of residents in our study was about 85 years old. Most of our residents, you can see about 3/4 were female. Most of the residents were white and not Hispanic. And if we look at the level of cognitive impairment, the average score on the SLUMS cognitive screen was 6.8. So they were moderately to severely cognitively impaired. And majority of residents had functional impairment. And when we compare these characteristics between our intervention and control groups, we saw that there were no significant differences across any of the characteristics except for the total number of comorbidities at the bottom. There was a significant difference where the residents in the intervention group had 2 more comorbidities on average than those in the control group. So this shows our brief results of our behavioral symptoms, our outcome on behavioral symptoms from baseline to 4-month follow-up. So these were the average scores on the MPIQ measure. And we looked at the number of behavioral symptoms, the severity of those symptoms, and distress related to those symptoms at baseline and at 4-month follow-up. So if you look at just those in the intervention group, you can see that from baseline to 4-month follow-up, there was a significant decrease in the number, severity, and distress related to the behavioral symptoms. And then if we compare the control group, there was actually an increase in the number, severity, and distress of behavioral symptoms from baseline to 4-month follow-up. This is looking at just the number of behavioral symptoms. So again, we can see here in the line graph, the red line represents the intervention group. The blue line represents the control group. So if we look over time, you can see that those in the intervention group actually had a reduction in the number of behavioral symptoms, which was significant. And those in the control group had a significant increase in the number of behavioral symptoms over time. So just thinking about the pilot study, obviously there's some limitations I always want to acknowledge. This was a small sample of residents from only 5 assisted living communities. They were all in Maryland. The sample as a whole lacked diversity among participants, particularly among racial and ethnic diversity and gender diversity, although it was fairly representative of the assisted living population nationally. And the outcome measures we used to measure behavioral symptoms were all based on proxy report. But there were also some strengths of the pilot study. This was a theoretically based intervention. I mentioned we used social cognitive theory for a number of the approaches for the intervention, and also based the intervention on the social ecological model. And in terms of the study methods and the analytical approach, were relatively robust. In terms of the take-home messages, really the key take-home message that we found is that meaningful activity is a beneficial approach for addressing behavioral symptoms, and they can be implemented in persons with dementia. So we actually looked at both the preliminary efficacy, but also the feasibility of the intervention. And we were able to implement this in a sample of assisted living residents with dementia. We also found that exposure to this intervention actually helped to reduce behavioral symptoms from baseline to follow-up. We're still analyzing sort of the long-term sustainability of the intervention, and we'll ultimately be looking at also at a 12-month follow-up time point. So when we think about optimizing meaningful activity, we know it really requires a multi-dimensional approach. We know it's challenging to change behavior, so we really have to think about addressing factors at the individual level, interpersonal level, and community level to really kind of address and engage residents with dementia in meaningful activity. So it's important to focus on addressing individual factors, thinking about what are some motivational issues for that particular individual that we can overcome, or thinking about, pain or other symptoms that may be impeding the resident's ability to participate in trying to address those. We also need to focus on providing encouragement for staff and for residents using some of these self-efficacy based approaches. We did contests for staff where we would highlight staff who were engaging residents in meaningful activity, a number of other different approaches that we use, but it's really important to encourage that piece of the puzzle. And then also thinking about the environment and policies, and thinking about what barriers might exist and how you can overcome those barriers. So I'll share kind of some lessons learned from our project. The first is really engagement with the staff. We worked with a team, actually a stakeholder team of administrators, managers, and direct care staff in the assisted living communities where the intervention took place. And they were all really critical for the implementation and also the sustainability of the intervention. So we worked together to come up with community-specific goals, and we worked together to address those goals and accomplish those goals. I'll share an example from a couple of our communities. One assisted living community that participated in the study actually through the intervention made it a routine practice that all new residents who moved into the assisted living community had a meaningful activity tool completed and added that to their chart. This is a way that we were able to change one of the processes and actually encourage all residents to have this tool completed. Now, a challenge is, what do you do with that information, and how do you actually implement the meaningful activities that are identified and encourage that over time? Another community, I'll share another example, was a continuing care retirement community. So they had independent living, assisted living, and nursing care. And they actually established with us a meaningful moments volunteering program is what they called it, where the independent living residents would come to memory care in assisted living where our study was taking place. And we paired the independent living residents with memory care residents, and they so they had the resident that they would meet with on a weekly basis. They knew a bit about them because they had completed the meaningful activity tool, and they really focused on those individualized meaningful activities and doing that together. So that was kind of another way that the community kind of took ownership and said, this is a program that we want to see and sustain here after the study ended. In terms of next steps, we're continuing this work and excited to be now working on a new study where we're exploring the implementation of meaningful activity and whether it can help to impact sedentary behavior of residents. So if we can get residents to be more engaged, can they also be more active and physically active? And so hopefully we'll be able to share more about that study in the coming months, but we're happy to be here, and I'm happy to answer any questions you have about our work. And thank you again for your time.
Wonderful presentation. Thank you so much for sharing your work. Any questions from the audience? While people are gathering the thoughts, thanks for really sharing your experience and the theoretical framework that based this study from. Dr. Kathleen Hall asked one question regarding, is there a stage of AD that your program is primarily recommended for, or it is suitable for any stages?
That's a really great question. And sort of, I'll answer it in a couple of parts. So I think in general, the meaningful activity program and intervention could be implemented in any stage, from mild cognitive impairment to advanced dementia. We had a majority of the participants in our work were moderate to advanced dementia. So we actually included residents who weren't able to communicate, but they were able to engage, and we knew enough about them that we could try to incorporate what we called even brief, meaningful moments. So it's really intended to be able to be customized and flexible to the individual. And that's why, we haven't actually tested it in more mild dementia or MCI, but, I would think that it could be adapted for any of those populations.
Awesome. Thank you very much. Dr. Hall, do you want to ask any follow-up questions, or you're good?
I think I'm good.
Yeah, we have the chat coming through, and is it possible to have a copy of assessment for everyone?
The meaningful activity assessment tool.
Yes.
Yeah. So, well, for our study, we completed it for everyone who was participating in the study. I do think it's possible to complete it on everyone, and I think I will even go so far to I think it should be completed on everyone. So part of what we've done, I don't know if we've been successful at this so far, but what a goal of mine is that this tool could be integrated within service plans or care plans, right, for all residents who are at admission, but then also updated frequently, so over time, as the resident's condition changes, the meaningful activities, their abilities, their interests, what they can do, what they enjoy doing may change as well. So I would think that this could be incorporated through, like I said, care plans, service plans. We've also seen it integrated within life enrichment and activity staff, who sometimes will have a screening tool. So they'll embed the meaningful activity tool within that. But certainly I think it could be completed on everyone.
All right. If you want a copy of it, you can email Dr. Holmes right in the screen. The email is there. So
Absolutely.
yeah.
Yeah. Happy to share it. And we actually also publish, I can also share the publication in
That would be great.
Agenda.
Yes, yes, yes. And then we have how important our staffing level are to the success of the program.
That's a really good question. So, staffing level, we know in assisted living and nursing home and across the board in all care settings, there's staffing shortages, and there's a lot of, it impacts their ability to be able to do things like assessment tools and things. Part of what, we try to change that philosophy a little bit or push it forward and thinking, okay, if we can engage residents in more meaningful activity, does it actually help the staff? That's one of the things we try to kind of promote among the staff. If residents are helping to set the table, maybe that's one less thing that the staff has to do. Or, if residents are engaging in meaningful activities, maybe they have less challenging behaviors that are difficult for staff. So I certainly do think that staffing levels make a difference. But I also see an opportunity where maybe this could be beneficial for both staff and residents.
And you're being interactive with staff and residents. So I thought that was really nice. And then there's another question. Are you able to share? Oh yeah, that was also, yeah, assessment tool is available for your publication. And
Yeah,
then
please email me.
yes, please email Dr. Holmes. And then Dr. Kim asked about, could you please share more details about the intervention, such as duration and frequency? Also, have you had a chance to track the number of meaningful activities completed and whether that is associated with better outcomes?
That's a great question. So a lot of that gets at some of the feasibility of the intervention and the feasibility data that we collected. We had a research interventionist who helped to deliver the intervention. They worked closely with, I mentioned, the stakeholder team within the community. And so they would go weekly, typically for about 5 hours per week. It sort of ranged depending on the week. And so they would go and check in with staff. They would do things, as I mentioned, contests, help to encourage completing the tool, and then, transferring that tool and translating it into practice. So in terms of the amount of time and the duration, it was, a weekly visit, sometimes 1 to 2 visits for about 3 to 5 hours. And I'm trying to think, in terms of the number of meaningful activities completed, we didn't actually track that in our initial study, but it's something that we're looking at now as we've adapted and are looking at sedentary behavior as an outcome. So we're pilot testing this, and we're looking at whether or not the participants actually participated in meaningful activities. What we know from our original study that I presented is anecdotally, we saw an increase in residents participating in meaningful activities, and we had a number of stories and case examples for them doing that, but we didn't actually record the number of activities completed.
Yeah, there's another question. Were the activities one-on-one or were they group activities?
Good question. It varied. So we encouraged, if there was a group of residents who all maybe had similar interests around reading, or one community actually created a coffee club where there was a group of residents who, enjoyed drinking coffee in the morning, and they would kind of engage in discussion, and that was meaningful. So sometimes there may be group activities where it made sense. Other residents, and especially those with more advanced dementia, often was an individual one-on-one. I mentioned kind of more brief, meaningful moments. maybe, including or having them participate in their own self-care, eating and dressing and grooming. So often those were some meaningful activities. And the family members and staff would report that, the resident, when they were, involved in those, that, they observed changes in their behavior.
What about whether the participant in the control group involved in the group activity offered by the therapeutic rec? There would be some contamination or
Yeah, well, so both of the communities still had their usual care. So both the intervention and the control assisted living communities had, recreational life enrichment activities. They were very similar in terms of the activities they provided. They had activity calendars, typically every day, morning, midday, and afternoon. There were things happening. So those existed in both of the communities. What was different was that we actually provided the meaningful activity intervention in one and then only education in the other.
awesome. Now it is 5:29. I'll close the discussion, but I have Jane, Margaret, and Faye's email for Dr. Holmes to share. I will email you, Dr. Holmes, for sharing your publication with the audience. And also, please fill out your surveys just in case if you haven't done that already. And then also we have next fireside chat scheduled next month with Dr. Letha Joseph, and it will be at July 23rd at this time this next month. So she'll be talking about the implementation of patient priorities care in a geriatric primary care clinic. And Dr. Holmes, do you want to share any last minute comments or anything that you want to add? I feel like this 15-minute went really fast.
It did go fast, and I'd be happy to follow up with anyone who's interested in getting more information, setting up private chats or conversations. So please send the emails to me, and I'd be happy to follow up with you. I appreciate your attention and your interest in this work. Thank you.
Right. Recording will be available around 2 to 3 weeks from now. And also, please stay tuned for our e-blast email for next month's speaker. And don't hesitate to contact me to relay messages to Dr. Holmes, or you can directly email Dr. Holmes for any questions. All right. Thank you, Dr. Holmes, for a wonderful presentation. I learned a lot and hope everybody learned something today. All right. Have a great evening, guys. Bye-bye.
Thank you.
Bye.